So it's a pleasure to share with you this clinical case. It seems a little easy to manage because this is a 35-year-old patient. He had multiple antecedents of herpetic keratitis, and the last episode occurred several years ago. Visual acuity is limited to contour finger, and you see on the slit lamp examination the opacity of the cornea, and it is possible to perform endothelial cell count in the nasal, and the cell density is 1,700 cells per millimeter. Okay? So it seems easy to perform a DALC in this case. However, if you see on the right the pachymetry map, you see that there is a very severe thinning in the temporal part of the cornea, and the minimal pachymetry is 150 microns, and the cornea is really thin at the level of the trephination because you are supposed to trephine at around 8 millimeters in diameter, okay? So if you want to perform your DALC and to trephine first, you will perforate in this area. This is the OCT in another place. You see the thinning of the cornea in temporal, and you see the normal thickness in nasal, okay? So you see here the risk of perforation when you perform the first trephination during DALC. And the first question is, how is it possible to perform a DALC in case of severe thinning at the periphery? You have four possibilities. The first is to perform a trephination of 8 mm in diameter, but only 130 micron, because you know that it's only 150 micron deep. You should perform a penetrating keratoplasty, because it's too difficult to perform a DALC. You have a femtosecond laser and OCT, and you can adjust the depth of the trephination according to the thickness of the cornea. Or you try to thicken the cornea at the level where the cornea is thinned and to trephine normally at 450 microns. Maybe are there several other solutions, and in this case I will show you the one that I choose. Okay, to perform a small trephination. It's very difficult to obtain the big bubble technique, or if you just have a very superficial trephination. It's more easy if you have a very deep trephination, and if you want to have less astigmatism, you should have a very good trephination on the whole cornea. So I'll show you the answer, because I chose the last solution, to thicken the cornea where it is thinned and to trephine normally at 450 micron. I'll show you here. So you mark, and on the area of thinning, you inject water into the stroma to thicken the cornea, and then you can trephine at 450 microns normally, and then to bear the Descemet's membrane. I'll show you another time. So you inject water with a 30 gauge needle in the area where it's very thin, and then you trephine at 450 micron deep. Okay? You see here that you dissect a little skirt. But when you have bared your Descemet's membrane, of course you will have a normal corneal graft, and the risk is to have a gap here, of course, because you will have a very thin cornea at the periphery and a thick corneal graft in this part. So how to avoid a large gap between the graft and the recipient bed? This is the second question. So the first possibility is to tighten the sutures very tightly to compress the peripheral edge of the graft, to add a temporal conjunctival flap to avoid postoperative leaks, because you can have leaks if it's very thin at the periphery, to prepare a partial top hat lamellar graft to thicken the recipient bed, or to prepare a partial mushroom-shaped graft to thicken the recipient bed. So you remember that the cornea is very thin at the periphery. You have already bared Descemet's membrane, and there is a risk of gap if you suture a normal corneal graft. Okay, these are good answers. Thank you. So this is the patient before dark, and this is a mushroom, a partial mushroom, and this is the other solution with the partial top hat. So most of the time it's difficult to dissect a partial mushroom graft manually, and it's more easy to perform a top hat graft manually. So either you have a femtosecond laser and you can perform a partial mushroom, but it's difficult. If you don't have, I advise to you the manual one. So I think the good answer are C and D, and I show you the preparation. So you have the patient, you thicken the cornea by injecting water in the thin cornea, you trephine 450, you remove the entire cornea, and you dissect a small skirt in the area where the cornea is really thin, and you put your cornea on an artificial chamber, and you can dissect a cornea with a partial skirt. You remove the Descemet's membrane, and then when you adjust your cornea, you can put this little skirt in the lamellar pocket that you have performed just before. So you will have a thickening of the periphery of the cornea. Then you can adjust your sutures with the Placido ring, okay? It's not so easy to perform it. So this is a preoperative patient. In this place you have the thinning, and this is postoperative where you have the little skirt at the periphery with the arrow, and here is the thickening of your cornea in temporal. This is a lamellar graft, and if you focus just on the area of the little skirt, you have here the thickening of your cornea, and the patient recovers 0.6 with 40 minus 275 plus 1 at 6 months. Okay? Thank you for your attention.
Thank you, Marc.